of Breast Health, What Every Surgeon Should Know, organized by Department of Surgery in association with Association of Breast Surgeons of India. Yesterday, we covered the epidemiology, screening, and evaluation of breast lump. We saw basics of planning oncoplasties, followed by briefing about early breast cancer. Let us now continue with the academic feast that we started yesterday and explore further topics related to carcinoma of breast. I would like to invite Dr. R.K. Shinde, Professor, Department of Surgery, to chair the session that will be starting. Our first speaker for the day is Dr. Arunima Varma. She is Chairman, ASI Jharkhand Chapter, Editorial Board Member of IJS, Editorial Board Member of JMAS, Executive Member of ABSI, and currently HOD Surgery, Tata Motors Hospital, Jamshedpur. She'll be briefing us about benign breast diseases, what to do, what not to do. Over to you, ma'am.
Thank you very much, Dr. Darshana. And at the outset, I would like to thank the Department of Surgery of Wardha and also the ABSI for giving me this opportunity. Can I share my screen?
Yes, ma'am. You are co-host. You can share your screen.
Okay. Can you all see my screen, please?
Yes, ma'am. It's visible now.
Just 1 second. I think I might have to change my view. Yeah, so in the next 20 minutes or so, I shall be trying to talk to you about benign breast diseases, what to do and what not to. So to start with, benign breast diseases constitute the majority, that is 80 to 90% of reference to breast clinic, and they are 10 times more common than the breast cancer. And the incidence is underestimated because it is not well documented in literature. Up to 30% of these women who suffer from benign breast disease will require some kind of treatment in some time in their lives. And the suffering in BBD is less physiological but more psychological because the patient lives in fear of malignancy. And these patients also have unnecessary surgical intervention irrespective of the type of lesion. And this is not what is recommended. So why are the benign breast diseases important? They are much more commoner than the breast cancer. They can be difficult to differentiate from breast cancer at times, and an incorrect diagnosis and inappropriate treatment of these disorders may be associated with significant morbidity. So as the PGs are the target audience of this CME, I would just briefly take through one slide about the breast structure, physiology, and surgical pathology. So during the lifetime of a female, there are 4 types of ductules that are found in a female's breast. The type 1 is undifferentiated butt-like structures, which is seen in menarche and persists in a nulliparous woman throughout her age. It has high content of estrogen receptors and a high rate of cellular proliferation. The type 2 is more complex with higher number of ductules per lobule. And these are the 2 types of ducts and lobular carcinoma in situ originates. The type 3 is seen specially during pregnancy and lactation and is a more differentiated variety with low estrogen receptor content, low proliferative activity, and most frequently found in the Paris women. The type 4 has fully developed acini and is seen during pregnancy and lactation. And this is the 2 types of ductules where these benign breast diseases are usually found. That is the adenomas, fibroadenomas, and cysts. So coming to the classification of benign breast disorders, the most accepted is the aberration of normal development and involution, that is ANDI. And the concept of ANDI is that most benign disorders are related to the normal process of reproductive life. And it is a spectrum which ranges from normal to aberration and occasionally to disease. And you have to have a pragmatic approach when you're defining a normal and an abnormal condition. It embraces all aspects, which include symptoms, signs, histology, and physiology. So looking at this table, you can see that the women age has been divided into 3 stages. That is early reproductive, which ranges from 15 to 25 years, mature reproductive, which is 25 to 40, and involution, that is 35 to 55. The early reproductive normal process is lobular development and stromal development, and this is the age at which nipple eversion occurs. The aberration would lead to fibroadenoma or adolescent hypertrophy or a nipple inversion. And the disease format is seen in the form of giant fibroadenomas, gigantomastia. The mature reproductive stage, there is cyclical changes of menstruation, which aberration would cause cyclical mastalgia and nodularity. And in a disease format is the incapacitating mastalgia. There may be epithelial hyperplasia of pregnancy, and at times these patients may present with bloody nipple discharge as well. The involution stage, you have lobular and ductal involution, and these lead to macrocysts and duct ectasia or nipple retraction. In case there is this stage, there is usually a high epithelial turnover. And if it is simple epithelial hyperplasia, it is an aberration. And if associated with high atypia, then it becomes a disease. There is another group that is the non-Andy group, which is a well-defined, there are well-defined conditions in this group, such as fat necrosis and abscesses, which may be lactational or non-lactational. So what is the aim of breast assessment? It is to obtain a definitive diagnosis in a timely way. There should be only 3 routine assessment outcomes. One is no significant problem, a diagnosis of benign lesion, a diagnosis of cancer. The assessment only ends at diagnosis and not before that. So triple assessment is what is done for any breast lesion, which is clinical breast examination, imaging, and core needle biopsy. FNAC is no longer the standard of care, except in certain situations, which we will also discuss in the later slide, that is aspiration of cysts. So when we will discuss it. So triple assessment, you have a equal role of breast surgeon, breast radiologist, and breast pathologist, and you have to work in close collaboration because each one has an equally important role to play. So coming to the diseases one by one, in the early reproductive life, breast aberrations and diseases, fibroadenoma is the most common condition which we come across in our clinical practice and is a discrete benign tumor which shows evidence of connective tissue and epithelial proliferation. And it can be of intracanalicular or pericanalicular type. Most commonly, it is found in 15 to 30 years of age group and is a rubbery, firm, smooth, or slightly lobulated and a very mobile mass, which is also known as the breast mouse at times. Radiologically, what you see is an oval, smooth structure with internal echoes and partial transmission, and it shows edge shadowing. You can see it in this picture. This is what a fibroadenoma looks like. So there are few variants like giant fibroadenoma. A fibroadenoma of the size greater than 5 centimeters is what is a giant fibroadenoma. Multiple, when there are 5 or more than 5 lesions in a breast. Juvenile, when it occurs in adolescent girls. And this is a special variety as it has a rapid growth and maybe more cellular than the usual fibroadenomas. A complex fibroadenoma is one which is associated with adenosis or sclerosing adenosis along with the fibroadenoma. So treatment-wise, what to do is you do not do an FNAC, you do not excise a fibroadenoma usually. Ultrasound guided core needle biopsy is what is recommended. And once you have diagnosed these conditions, what is needed is reassure the patient. Only in the conditions that I mentioned, like giant fibroadenoma and all, that you may excise, or if the patient is very persistent. Otherwise, no. Even when you come across young ladies with multiple fibroadenomas, do not excise them. What is required is convincing and counseling them that this is not dangerous after you have done a core needle biopsy. This is one of my patients, and you can see that this is a giant fibroadenoma, which is more than almost 8 centimeters, which I have excised. And there was another associated smaller fibroadenoma, which has also been excised along with this excision. But if it was just the small one, no. Another variety is the phyllodes tumor, which is usually seen in the age group of 30 to 50 years and is known as the more aggressive counterpart of the conventional fibroadenoma. It is confused with it, but it's a different entity. It grows rapidly and involves a lot of the breast. The cervix becomes unevenly bossulated and there is ulceration of the overlying skin due to the pressure necrosis. And despite their massive size, what is important is that these remain mobile over the chest wall. They can be benign, locally aggressive, and sometimes metastatic. Treatment-wise, a wide local excision with a 1 centimeter margin of normal breast tissue is what we usually do. But for massive or recurrent tumors or the malignant types, you may at times need what is a quadrantectomy or a simple mastectomy with reconstruction. This is the mammogram showing a phyllodes tumor. So again, repeating treatment, FNAC you do not do in these. What you need to do is an ultrasound-guided core needle biopsy and wide local excision, which I have already mentioned. Coming to the next stage, that is the mature reproductive life breast aberrations and diseases. Mastalgia is something which we all come across very commonly, and mastalgia can be cyclical or non-cyclical. Now, the non-cyclical mastalgia may be a true non-cyclical breast pain, or a musculoskeletal pain, or because of trauma, or some non-breast causes like cervical spondylosis, angina, or cholecystitis. The cyclical mastalgias are usually presenting with nodularity, which is mostly bilateral. They can be of varying degree, maximally in the upper outer quadrant, and they have similar cyclicity to the pain. The patients describe it as heaviness and tenderness to touch, and this pain may radiate to the axilla and down the medial aspect of the upper arm because it's a kind of a referred pain which travels via the intercostal brachial nerve. The clinical condition is designated as painful nodularity of Andy, and the pathological counterpart is known as fibroadenosis. Coming to the true non-cyclical mastalgia, these are not related to the menstrual cycle and can be found both in pre- and postmenopausal women. They may be unilateral or bilateral. Pain is well localized in the breast, more frequently in the subareolar or upper quadrant, and the patient describes it as burning or drawing pain. The pain in this variety is usually of a lower intensity, and nodularity also is less prominent than the cyclical pattern. But in these, you may find some trigger spot zones. Now, what is important is that you have to examine the patient for knowing that these non-cyclical mastalgia are true mastalgia, that is breast pain, or are they chest pain. For this, a thorough examination of the patient with the patient either turned to the side or by asking her to lean down so that the breast falls away from the chest wall is important so that you can examine the chest wall as well as breast separately to know where the pain actually is. So there is a huge armamentarium of treatment that we come across in the form of hormonal manipulation and non-hormonal agents. But what needs to be done in nostalgia is that you have to counsel your patient for a proper breast support. And a proper breast support usually means a correct fitting bra, can be advised to use topical NSAIDs like NSAID gels. If the patient is on OC pills, ask her to change the contraception mode to some kind of barrier contraception. Very rarely you can prescribe tamoxifen for a very short period, 10 milligram twice a day. And if you have diagnosed that the pain is not a breast pain but a chest wall pain, local anesthetic injection can be given. What not to do is, which is very commonly done, is vitamin E, primrose oil. These are actually placebos and do not help, so not to be given. Antibiotics, restricting tea, coffee, again not to be done. Next condition that we come across commonly is a nipple discharge, which is defined as spontaneous efflux of fluid from the nipple apart from the physiological function of puerperium and lactation. And these nipple discharges can be grouped into physiological galactorrhea, secondary galactorrhea, opalescent or colored opalescent or grumous discharge, and serosanguinous or watery discharge. So this is a table which describes the type of discharge and the main causes. The blood-related or bloody, serous and watery discharges are mostly related to hyperplastic lesions, which are hyperplasia, papilloma, carcinoma in situ, and invasive ductal carcinoma. Now, the color opalescent or grumous that we call is mostly associated with ductectasia. And milk is a physiological condition or at times may be associated with galactorrhea of endocrine origin. Again, these nipple discharges may be from a solitary duct or from multiple ducts and may again be unilateral or bilateral. So how do you manage them? Triple assessment again is very important. You have to do a triple assessment in these patients. Then there are a few special investigations which are not available and are usually not recommended as well, but you need to know that there is ductography and galactography. Occult blood test, when you are doubtful that the discharge that's coming from a single duct is a bloody discharge, you can do this. Management is usually based on the cause, and if it is physiological, endocrine, and drugs, then you just need to observe. But if it is watery, serosanguinous, and bloody discharge, then you need to exclude cancer and then observe. If you have diagnosed it to be a benign nipple discharge, then depending on what is the pathology, if it is from a solitary duct, you can do a microducectomy. If from multiple ducts, you can plan a major duct excision. And if there is a peripheral duct involvement, then segmental excision is what is needed. Moving to the next stage, that is involution aberrations and diseases. Breast cysts are very common in this age group and associated with active secretion of apocrine epithelium under hormonal stimulation is what leads to these cysts. It is seen mostly in perimenopausal women and the clinical presentation is smooth, discrete breast fluctuant lumps, which may be fluctuant or non-fluctuant, and cysts are visible and may even be painful. Diagnosis again is by ultrasound. As we mentioned in the earlier slides, aspiration I would talk about when to do, what not to, and cytological examination again only recommended when fluid is blood stained and when there is a residual lump. So this is a mammogram showing multiple breast cysts, and on an ultrasound you can see an anechoic, well-defined walls enhanced through transmission. So do we aspirate every cyst? No, you do not need to aspirate every cyst. You need not even send the cyst aspirate for cytology, culture, or sensitivity. And what has to be done is ultrasound guided aspiration, especially if the patient is having a large cyst which is causing discomfort, pain, or has become infected. There again is no need of cytology, culture, or sensitivity of the fluid. What actually is needed is an ultrasound guided core biopsy lesion of this intracystic lesion that you are seeing. Now, moving on to the non-anti-benign breast diseases, and what we very commonly come across is mastitis, which is a very common condition of the breast. And it is an inflammation which may be caused by an underlying infection. There are various types of mastitis, which starts from a puerperial or lactational mastitis, the non-lactational mastitis. And then there are special varieties like granulomatous mastitis, which may be tuberculosis in origin. It can be an idiopathic granulomatous lobular mastitis. So these are the special varieties. Coming to breast abscesses, these develop as a complication of lactational mastitis in the incidence being 0.4 to 11% of all lactating mothers. The non-lactational or non-puerperial abscesses have been observed more in obese patients and smokers compared to general population. So what needs to be done in breast abscesses is you have to have an early recognition. Do not wait for fluctuation to appear. Antibiotics and ultrasound guided aspiration or catheter drainage is what is now recommended. The organism usually implicated is Staph aureus, and antibiotics directed against it is flucloxacillin, augmentin, and erythromycin. Patients should be asked to continue to breastfeed because bacteria and antibiotics will cause no harm to the baby. So encourage breastfeeding. What not to do is antibiotics like ciprofloxacin and tetracycline should not be given. Do not suppress lactation. Ice packs not to be given. Incision and drainage should not be done, especially as the first line of management. They can be done as the last resort, not the first. So what you see here is a needle that you can see inside the abscess cavity, and this is aspiration that you do. And in this video that you're seeing, what we have done is we have put a catheter under ultrasound guided catheter drainage has been done. And you can see that a large amount, this was a very big breast abscess that we had come across, and we aspirated almost 100 ml and then left the catheter for 3 to 4 days, kept washing it with 20 ml of saline with betadine, and it was aspirated. And after the 4th day, the patient had a good response and we took that out. Again, a condition when you come across a post-lactating lump, do you aspirate it? No. Only you aspirate it when it is large, causing discomfort or is infected. That's an infected galactocele. As I mentioned, there are other mastitis. So coming to granulomatous mastitis, it is predominantly lobular granulomas and there is absence of caseous necrosis in them. Tubercular mastitis is usually centered around the ducts rather than lobules, which is different from granulomatous mastitis, and they have the typical caseous necrosis. So coming to granulomatous mastitis, it's a very rare chronic inflammatory breast condition and it is of unknown etiology. Patients usually are premenopausal and they present with firm, unilateral and discrete breast mass, which may be associated with abscess or inflammation of overlying skin, and multiple fistulae may be seen. Locally, it may mimic carcinoma at times, and this is the reason why it becomes an important entity. It is a diagnosis of exclusion because you also need to exclude the other granulomatous conditions like tuberculosis, sarcoidosis, and venous granulomatosis. And we still do not have a accepted norm of optimal treatment of granulomatous mastitis, and what treatments are available are corticosteroid, antibiotics, abscess drainage, wide surgical excision, very rarely mastectomy with reconstruction when it is very difficult to treat them on these. There are other medications also mentioned in literature, but usually this is the armamentarium that is used. If we look at a simple algorithm, if it is a mastitis, if you come across a mass with unclear origin, then you do a core natal biopsy, which if shows granulomatous mastitis, you may start on high dose prednisolone. In case of insufficient response, you may go to surgery. But if it is already diagnosed as cancer, then oncologic treatment. This is one of my patients who had come with multiple discharging sinuses, and histopathologically, after exclusion of all other causes, we came to the conclusion of granulomatous mastitis. Despite treatment not responding, so we did a wide local excision, including the affected lobules, and then she did very well. You may come across a mammogram like this, and the patient is worried that she has cancer, but maybe that these are recurrent abscesses that you come across. So what to be done? Definitely, this is not something that you should done. This is what happens when you have done multiple incision and drainage in a patient like this. A young patient has a disfigured, scarred breast. What is needed is that this is a case of tuberculosis. When you find caseous necrosis in a patient, this is what you have to start ATT, because usually you will not find AFB on stain. Even the culture will not yield the acid fast bacilli. Tubercular bacilli is not found because this is a paucibacillary kind of infection. But once you are convinced that this is tuberculosis, you have to start empirical ATT after good consultation and counseling of the patient. And once the patient starts responding, the patient will be convinced. There's another condition that you very commonly the axillary breast tube. And is the treatment excision? No, just reassurance is what is needed for these patients. It will just unnecessarily cause scarring, and the scar tissue itself may cause pain at times. So just reassure the patient. There's another condition which we very commonly come across because mammograms are frequently done nowadays, benign macrocalcifications. This is fingerprint artifact. So be careful about it. These are not microcalcifications that you should be worried about. You can have vascular calcifications, which are generally diffuse and thin, and they involve the entire circumference of peripheral arteries, making the vessels rigid with little capacity for distension. They are usually found in patients older than 50 years and are found in almost 9.1% of mammograms. We may come across secretory calcification. This is what it looks like in a magnified view. They are benign calcifications seen in women older than 60 and appear as solid or discontinuous, smooth, linear, and rod-like calcification, also known as plasma cell mastitis. This is what another condition that is oil cyst, which is seen in all ages and ethnic groups and has a female predilection. It may be associated with trauma if it is found in males. And these are just that because of trauma, there is fat necrosis and it becomes walled off by fibrous tissue. So what do you need to do? Do nothing, and even no follow-up instructions. Just once you are convinced that these are the conditions of benign microcalcification, nothing needs to be done. Just a mention of another few benign conditions: sclerosing adenosis, observation, reassurance. If troublesome, discharge, treated surgically, usually by total duct excision. Periductal mastitis, surgical excision of diseased duct alone or total duct excision. And if it is epithelial hyperplasia, if it is mild or moderate, without atypia, no further follow-up required. If it is moderate with atypia, then you need either a close clinical follow-up with mammographic surveillance, or they may enter into prevention studies, may at times need mastectomy or with immediate reconstruction. So my acknowledgements are to ABSI for sharing the teaching module and my patients for teaching me. And my takeaway message would be benign breast diseases are very common. They are not life-threatening, but may be associated with high morbidity and psychological stress. So surgeons should take due interest in BBD and avoid inappropriate management. Large proportion of BBD can be managed by listening to patient and reassurance. Thank you very much for your patient hearing, and this is where I work and my team. Thank you very much. I'm happy to take questions.
Thank you, ma'am, for your nice talk on benign aspect of the diseases of breast. I would request Dr. Shinde sir to add on few points.
Excellent presentation, but for PG purpose, I would like to know from Madam, enucleation versus excision in the fibroadenoma patients. Number two, the size of cyst that requires aspiration in the breast cyst. And what we are taught since our PG, abscesses are usually multiloculated. So in such cases, and in the large abscess, there is a large cavity, and then again there is a serous filling of this cavity So how to manage these patients? If that is being elaborated, that will be better for everyone.
Yes, sir. Thank you very much for this question, sir, and your brilliant observation. So as far as fibroadenomas are concerned, enucleation is good enough. We do not need to do a local excision, wide local excision. Enucleation is what we usually do. In complex fibroadenomas, if you come across, you may do that, but enucleation is good enough for fibroadenomas. Coming to your second question of breast abscesses being multiloculated. So usually the first line of treatment is antibiotic, as we said. If it is a big cavity, then we do aspiration, and multiple studies and even a RCT is going on about aspiration and a catheter insertion. Catheter insertion is supposed to cause less scarring, but multiple aspiration under ultrasound guided drainage is also a good condition. Usually when it is, it infects the breast abscess, if it has caused local necrosis of the skin and all, that is usually the time when an incision drainage has to be done. So this, and third question, sir, I just forgot. Can you just repeat your third question?
The cyst that needs aspiration.
So, sir, cyst, already I mentioned that if the cyst is very tense and is very painful, those are the cysts which need aspiration, or if they are infected. Otherwise, usually about 5 centimeters is what would become a tense cyst, which will be causing pain. So those are the cysts which will need aspiration. Otherwise, you can just observe the cysts.
Some controversial view regarding the primary antibiotic in the abscesses, because if we use antibiotics before drainage, either way, either open or the aspiration, it will lead to antibiomas. So how do we deal with this? Usually what we say is, in the cases of mastitis, we should try for the antibiotic therapy. Once the abscess is formed, it needs to be drained. But you are treating this patient, or you are advising that the patient should be treated primarily with the antibiotic, even if the abscesses are formed. So this something.
Sir, abscesses, once the abscess is formed, you need to aspirate.
Yeah.
So what I talked about was have a close observation. Once in the mastitis stage, you need to start with antibiotics.
Yeah.
And once abscess cavity has formed, then you definitely need to intervene either by doing an aspiration or doing a catheter drainage. And if, as I mentioned, if you're seeing signs of changes on the skin, then you might need an incision and drainage.
Yes, thank you. Any other questions from any audience or any input? Because everything is excellently dealt by madam. So I don't have any other observations or any inputs. So if anyone has, they can intervene.
Yes, sir. There are few questions in the chat box which I would like to put forth.
I have one question.
Ma'am,
Yeah.
there is a first question is that if the abscess is of minimal size, then what should be the plan? When to go ahead with IND or just to stay with aspiration of the
aspiration
abscess
is
cavity?
what is very small abscess. Again, there is no question of doing an IND. Definitely an aspiration. And as I mentioned, and sir already mentioned, it may be multiloculated. So if they're very small ones, and if the patient is not in sepsis, you can actually observe with antibiotics for some time. You can. They do respond well.
Madam, I got one question, please. May I ask one question?
Yes, yes, sir. Go ahead.
Yeah.
Yes.
Suppose there is an ND. Do you prescribe B complexes to these patients?
No,
what is the role of B complex? Because I read there is a role of B complexes. So do you regularly or routinely advise B complexes to the patient having ND?
No, sir. Nipple discharge patient, again mentioned, what you need to do is triple assessment. We do not prescribe any B complex for nipple discharge.
No. Why I am telling you? No. I have read in the books. There is a role that in presence of B complex, estrogen metabolism is enhanced. So estrogen, whatever, that will get reduced and that will give a relief to the patient. So it is given in the textbook. So I'm just asking whether regularly you advise B complexes to the patient or not.
No, sir, I do not do it in my practice. Maybe some others can add to it, because nipple discharge, again, as I mentioned, depends upon what is the cause of your nipple discharge. So even if it is endocrine dependent is what you're talking about. I do not use, but yes, somebody who has used can add to it.
Okay. Now, excision, Other question is, in benign condition, we do some excision, and you have shown me some photograph along with the skin. Now, what do you refer these patients for any, what is that called, reconstruction?
Sir,
Because
what?
there is a disfigurement.
Yes, sir. There is disfigurement. So it, sir, what I have excised, this was a large size breast. You could have seen. So the skin was not very maximal that I have excised. It wasn't. So the disfigurement was not much, and the patient did not want to have any further, because see, once you have excised, you also need to wait. You cannot go in for immediate reconstruction, because we have excised the reason, but that patient. Yeah, you can offer, yes. If the disfigurement is very obvious and the patient wants, you can refer the patient for reconstruction. Yes, definitely.
Okay.
One more addition for the abscess part, that what is the criteria or cutoff level to go ahead with IND and not to proceed with aspiration for that abscess?
So, ma'am, as I mentioned, I showed you in the slides that there was a video. It was a very large size abscess, almost a 10 centimeter abscess, where I had put a catheter. So I had put a catheter and I had left it in situ for 4 days. So nowadays, even catheter drainage is what is recommended. And I said that there is a RCT that is already going on about that, which is a better method. So hopefully by next 21, we would be having a better answer also to that. But even a large size abscess should not be drained immediately if you can manage it by aspiration and catheter drainage.
And one more query from the chat box, that what should be the management for mastitis and fibroadenosis?
Fibroadenosis depends. See, it's a hormonal condition. Fibroadenosis, reassurance, correct size bras, and at times, giving some analgesia, just in the form of paracetamol or local application of NSAIDs, they should help. They usually help. But in case that what we mentioned, it is again a cyclical pain. So you can give somebody also, I could see in the chat box, was asking about tamoxifen. It's a very short duration. Maybe you can give for 3 months and see the response. But that's also in a very later stage that you can try if it is, the pain is incapacitating. That is the time you can give.
I think it was a quite nice discussion, and almost all the topics regarding benign breast diseases have been covered.
Hello, Darshana ma'am.
Any more queries are there? Yes, Amit, welcome.
Ma'am, thank you, ma'am. First of all, I would congratulate Arunima ma'am for this fantastic presentation. This is second time in this month I am able to hear you, ma'am. I attended JASICon, which was fantastically organized by you. So there are few comments and few inputs that I would like to give. First is regarding mastitis. So ma'am, regarding mastitis, before starting hormonal therapy like tamoxifen or anything, probably the first line of management has now been, what has been advocated is use of flax seeds. So if you would like to add anything regarding use of flax seeds in management of cyclical mastitis. Second thing regarding breast abscess, I think you have very properly stressed on management of breast abscess by aspiration. So now the paradigm has changed. Actually, from incision and drainage, the morbidity which surgeons used to inflict on women, it is definitely going to change with this aspiration and aspiration. So how paradigm has shifted is, for all the breast abscess that are not involving skin, means that is not causing skin necrosis, has to be aspirated, either aspirated or has to be catheter drained, and appropriate antibiotics. So these are the things that I wanted to add. There are many questions regarding, because it is very difficult for us and for postgraduates to accept that breast abscess has to be drained only. But in our unit, in unit 1, we had started with this practice of aspiration of breast abscesses, and probably Meenakshi ma'am is very active in this regard. I think she has given a thesis also to one of her postgraduate students, and hopefully by end of next year we would get her results also. Thank you, ma'am.
Thank you, Dr. I think you reiterated what I had already said, that only when there are skin changes, you may have to do a incision and drainage. And as I said that in my unit, I have already started even the catheter drainage. So hopefully, as you teach the PGs, things change. From radical mastectomy to modified to breast conservation, we have moved. So hopefully for benign also, benign diseases, as you can see even in this CME that we are having, it's a small proportion. So it's less, studied, but definitely that paradigm shift has happened. And regarding the first flaxseed that you're talking about, my personal experience is absolutely nothing with it. I would, and RCT is not available. So I would not comment on that because this is for postgraduate teaching.
Okay.
But thank you very much for those observations. Thank you very much.
Thank you.
Thank you, ma'am, for such a nice discussion. Now we will move ahead with the session and we'll go to the next speaker of the day.